Welcome back to 10-Minute Community Medicine. Quickly before we start, please subscribe to the channel, like this episode and drop your next topic request in the comments. Your suggestions shape our syllabus. Today's topic is pneumoconiosis. With a quick dip into the Factories Act, Dr. Joshi, could you open with the definition and a simple classification that examiners like?
Certainly. Pneumoconiosis refers to chronic lung diseases caused by inhalation and deposition of inorganic dusts, followed by a fibrotic reaction in the lungs. The classic fibrogenic dusts are free crystalline silica, causing silicosis, asbestos causing asbestosis, and coal dust causing coal workers' pneumoconiosis, CWP. Less fibrogenic dusts include iron oxides and tin, which cause milder changes. For exam answers, classify by dust type, silicosis, asbestosis, CWP, and by radiological severity. For example, simple disease versus progressive massive fibrosis. Also mention key organic dust-related occupational lung diseases that are often discussed alongside pneumoconiosis in viva. Bagasosis from inhalation of sugarcane bagasse bust, typically contaminated with thermophilic actinomycetes such as Thermoactinomyces species. Bisonosis from cotton, flax or hemp dust, rich in bacterial endotoxin, and farmer's lung from moldy hay or grain dust containing thermophilic actinomycetes such as Micropolyspora fani. These latter entities present more as hypersensitivity pneumonitis, with cough, dyspnea, and sometimes fever, rather than classic fibrotic pneumoconiosis. But naming them with the causative dusts scores well in exams.
Let us structure clinical features by major types, starting with silicosis. What should a student write and say in a viva?
Silicosis presents after years of exposure with exertional breathlessness, chronic cough, and reduced exercise tolerance. The chest X-ray shows small rounded opacities predominantly in upper lobes, which may coalesce into progressive massive fibrosis. Silica impairs macrophage function, so there is strong association with tuberculosis, often called silicotuberculosis. Spirometry typically shows a restrictive pattern, sometimes mixed. Complications include respiratory failure, cor pulmonale, and increased risk of lung cancer. The diagnosis rests on a good occupational history, radiology read to International Labour Organization guidelines, and exclusion of other causes.
Case Vignette 1. A 38-year-old stone crusher has 10 years of dust exposure, chronic cough, weight loss and an upper zone nodular chest X-ray. Sputum for acid-fast bacilli is pending. How would you proceed, Dr. Joshi?
First, treat him as presumptive tuberculosis while confirming exposure history and prior chest films. Request sputum testing, provide infection control advice, and counsel cessation of exposure. He needs fitness assessment, spirometry, and referral for compensation guidance. If tuberculosis is confirmed, treat per national protocol, monitor closely because silicosis increases risk of complications, and ensure follow-up even after cure, because fibrosis progresses despite removal from exposure.
Now, asbestosis, the exam favorite with plural questions. What are the high-yield points?
Asbestosis is a diffuse interstitial fibrosis from amphibole or chrysotyl fibers, often in shipyards, insulation, brake lining, and construction. Clinical clues are progressive breathlessness and fine end inspiratory crackles. Chest X-ray shows basal subpleural reticulations. Pleural plaques and calcifications reflect past exposure. Two malignancy links are critical: malignant mesothelioma of pleura and bronchogenic carcinoma, the latter synergistically increased by smoking. Clubbing may be present. Diagnosis again hinges on exposure history, radiology, and supportive physiology.
And coal workers' pneumoconiosis or CWP?
CWP ranges from simple small opacities to progressive massive fibrosis. A subset with rheumatoid arthritis develops Caplan syndrome with necrobiotic nodules. Symptoms mirror other pneumoconiosis: exertional breathlessness and cough. Management is similar: exposure cessation, rehabilitation, vaccinations, and treatment of complications.
Students often ask what investigations and what to write first. Could you give an exam pad sequence?
Start with occupational history detailing job tasks, dust sources, duration, and controls used. Then clinical exam for clubbing, crackles, signs of cor pulmonale. Next, radiology, chest X-ray interpreted to ILO profusion categories. CT helps detail reticulation or pleural disease. Add spirometry to document restrictive or mixed defects and diffusion capacity where available. Evaluate for tuberculosis in silica exposed workers. Environmental assessment, dust monitoring, and walkthrough survey support preventive planning.
Management.
There is no specific antifibrotic cure for classic pneumoconiosis. Principles are remove from exposure, optimize bronchodilators if airflow limitation, pulmonary rehabilitation, manage hypoxemia, vaccinate against influenza and pneumococcus, screen and treat tuberculosis in silica exposure, support smoking cessation, and address psychosocial and compensation needs. For asbestosis, counsel on cancer symptoms and need for periodic surveillance.
Prevention wins marks. Could you frame primary, secondary, and tertiary prevention with examples?
Primary prevention is control at source, along path, and at worker. At source, substitution of high silica materials, process enclosure, wet drilling, and automation. Along path, local exhaust ventilation and dilution ventilation, housekeeping to prevent settled dust from becoming airborne. At worker level, personal protective equipment, PPE, such as properly fit-tested respirators, training, and job rotation as an administrative measure. Secondary prevention is health surveillance, pre-placement examination, baseline chest X-ray and spirometry, periodic medical examinations with ILO-style film reading, and environmental monitoring with threshold limits as per rules. Tertiary prevention is early diagnosis, rehabilitation, compensation, and re-employment counseling.
Could you walk us through a prevention-oriented case? Case 2. A small quads crushing unit reports 2 workers with exertional dyspnea and abnormal chest films. The owner says masks are expensive. How would you apply the community physician lens?
Begin with a walkthrough survey to map dust-generating steps. Recommend wet methods at crushers, local exhaust hoods at transfer points, enclosure of conveyors, and regular housekeeping using wet mopping rather than dry sweeping. Propose engineering first, then administrative controls like shorter exposure blocks and rotation, followed by PPE only as a last line. Arrange pre-placement and periodic medical exams, chest X-rays read to ILO standards, spirometry, and a health register. Educate the owner that respirators must be fit-tested and replaced as per guidance. Link the unit to government schemes or boards for compliance support. For affected workers, ensure referral, compensation counseling, and smoking cessation support.
Students stumble on differential diagnosis. What should they name quickly in a viva?
Consider tuberculosis, chronic obstructive pulmonary disease, hypersensitivity pneumonitis from organic dusts, and idiopathic pulmonary fibrosis. The occupational timeline, dust type, radiology pattern, and pleural findings help differentiate. For example, pleural plaques suggest asbestos exposure. Upper lobe nodularity and tuberculosis risk point to silicosis.
Any must-remember worker education points to close the counseling loop?
Yes, teach correct respirator use and seal checks, encourage smoking cessation, report breathlessness or cough early, take breaks in clean areas and practice personal hygiene, changing clothes and showering to reduce para-occupational exposure at home. Emphasize that cough and breathlessness after years of work are not normal aging, but potentially compensable and preventable disease.
A short consolidation, please, something we can write under exam pressure.
Definition: pneumoconiosis is lung fibrosis from chronic inhalation of inorganic dusts. Types are silicosis, asbestosis, CWP, with simple and progressive forms. Risk settings are mining, stonework, foundries, shipyards, insulation, and coal mines. Features are exertional breathlessness, cough, restrictive physiology, and characteristic radiology. Silicosis links strongly with tuberculosis. Asbestos adds pleural disease and malignancy risk. Diagnosis is by occupational history, ILO red X-ray, targeted tests. In management, there is no cure. Remove exposure, rehabilitate, vaccinate, treat complications, and support compensation. For prevention, engineering controls, ventilation, housekeeping, PPE, and surveillance. Factories Act mandates dust and fume control, ventilation, protective gear, medical examinations, health registers, and monitoring for hazardous processes.
Final self-check. Pause and recall. Which single preventive measure should always be attempted before relying on personal protective equipment or PPE? If you said engineering control at source, you are exam ready. Thank you, Dr. Joshi, and happy revising, everyone.